Okay, so thank you for joining us today. Today we have a taster lecture on population data science research and using data to support policy sciences and COVID-19 responses for Wales and in the UK. So we're very privileged today to be joined by Dr. Ashley Akbari. He's a senior research manager and also a data scientist, and he also teaches on our BSc Population Health and Medical Sciences program. So thank you, Ashley. Over to you.
Brilliant. Thanks, Cecilia. So just to say welcome to everybody, I'm just going to say a couple of apologies. My children may be coming home at some point during the session, so if you hear noise towards the end, apologies. And the same, my dog might start barking, but we'll go through it together. Okay, so yeah, I'm just going to give a talk today for about half an hour, 40 minutes, just on the use of linked data to respond to the COVID-19 pandemic in Wales, using data to support policy, services and the response. I'm going to do a little bit of background on what is population health and what is population data science, how we do that at Swansea, and then some of the work that we've done around this in Wales, responding to the COVID-19 pandemic. Okay. So first of all, just a slide or two around what is population health and what is population data science. So these are becoming more well known now over the last couple of years. People use them both interchangeably and separately, but essentially they are around looking at different models and methods and techniques for looking to understand and improve people's health through the use of data and through the use of information and expertise. They can be used in a local setting, a national setting, or even an international setting. What we're going to be talking about today is their use around sort of redesigning or evaluating the use of services in the NHS, social care services. But the main thing is that we're looking to lead to improvements in terms of services or the development of new services. Okay. There's lots of different determinants that go into these things, and there's a couple of nice images on the slides that show you this, but essentially the core message from this is that there are a lot of different things that you might not consider would be factors or determinants in understanding people's health, but it's not just usually their health that plays a role in this. There's also a wider different array of health, wealth determinants, as we call them. So people's work, are they unemployed, their kind of monetary situation, the different services they have available to them, their education. So a wide variety of different things that play a part in this. And the different interventions that we could look at, once again, aren't just isolated to changes to the NHS. So there's a lot of different things that we could look to investigate that would either directly or indirectly play a role through different policies or different interventions that would have an effect on people's health and well-being. And there's just a nice little quote or two here about what population health is. And really the main message that I would bring through here is that it's a very multidisciplinary approach. It requires a lot of different people, different expertise, different backgrounds to really draw out the strength as to how you do some of these things. And really needs a coordinated, proactive approach when it comes to bringing these different specialties together. And from our point of view, linking back to population data science, then a wide array of different data sources that would inform some of these evaluations or interventions. And it's a growing demand as well. So population health is a really rapidly emerging discipline, as I mentioned. It was one of the top jobs a couple of years ago from industry in terms of recruiting people. There is a real shortage at the moment in terms of experienced expertise around data science. So it is an attractive area to look to develop into. And as Cecilia mentioned, we've got a couple of different courses here at Swansea that focus around this. One of these is the Population Health and Medical Sciences degree. There are also a wide array of other undergraduate and postgraduate degrees that touch on population health and population data science as well. So a little bit more about Swansea in particular then. So Swansea has a very strong role across the UK in data science. This is a nice image that just displays some of the different research programs and projects that we're involved in. These are all either led from or Swansea is a part of these different programs across the UK. And the main thing I draw from this is that The green bubble at the bottom is the technology that we develop at Swansea, which empowers all of these different research projects and programs. But they all have interdisciplinary research, and a lot of the time, although they're quite specialized in the area that they're focused on, there's a lot of learning that we can transfer between these, and we do that a lot. So we're very collaborative at Swansea in terms of who we work with and how we learn from each other. I'm going to just talk about a couple of the major research centres that we have at Swansea that were on that diagram. So the first one is Health Data Research UK, which I primarily work for. This came forward from something that used to be called the FAR Institute, and essentially now is a list of different organisations across the UK that come together and are looking for cutting edge data science approaches to improve people's health. This came from the FAR Institute, as I mentioned, and what can be really seen from the image on the FAR Institute is why I like showing it is, although we're mainly focused on the UK, you can see here across the list of collaborators, this really was a worldwide collaborative effort in terms of the different people that work together. So from the title, as you would imagine, health is in the title. So Health Data Research UK is primarily focused on health. Another one of the programs that we're involved in is Administrative Data Research UK, or Wales, which we are the site of. And this is more focused on non-health data, so more in terms of policy, government, other data, administrative data, if we call it that, that obviously learns from and benefits from health data, but is interested in some other types of data. So I'll draw on some of these in a minute when I show some of my further slides. And I'm hoping the audio works here, but I'm just going to show you a quick video now, which comes from Data Saves Lives and Understanding Patient Data, who are two groups across the UK that do a lot of work when it comes to understanding how people's data is used and where it comes from. And it's a nice little video that shows you a little bit about where we get some of our data from and some of the considerations. So I'm going to press play now, and hopefully this works and the audio comes through.
This film has been produced by publicly funded organisations to help answer questions about how your patient data is used by universities, researchers and scientists to save lives. Sharing patient data with universities and researchers has a positive effect on health and social care across the UK.
I've been meaning to ask, what do people mean when they say patient data?
The NHS sees hundreds of thousands of patients every day, and each time data is recorded, stored digitally, and used to provide you with care based on your medical history. But your data can also be reused in medical research.
So who actually does the research?
Universities and researchers are able to bring together information from all over the NHS and other sources too, and use it to create a better overall picture of health. Often, research done by universities involves NHS doctors. They provide the medical expertise, but work with academics and researchers to help them design meaningful studies and analyse extremely large amounts of data.
Why do they need to use my data?
Because everyone is different, looking at individual patients makes it very difficult to know why some people get sick while others don't. But when we look at the information from everyone in a city, or even a country, patterns emerge that can help us understand what's going on. It isn't new. For decades, patient data has been used to discover big health improvements that wouldn't be possible otherwise. For example, understanding that cycling to work can help reduce the risk of heart disease and cancer, or improving our understanding of how asthma develops in children. By analysing the ways that health services are used, researchers are using data to create modern and efficient services that are a better fit for the people that use them, making sure that all patients get the right treatment in the right place at the right time. Who is my data being shared with? Is it safe? Researchers accessing patient data need relevant training, qualifications and security authorisations. They must prove that the data will be handled in the safest and securest way possible and only ever used to improve human health. Before university researchers can access patient data, name, date of birth and address are removed. Researchers are only ever given the minimum amount of information they need to do their work. The good news is, patient data is already safely and securely used by UK universities to inform healthcare policy, create new treatments, and extend the lives of mothers, fathers, friends and children all over the UK. If you want to know more about your patient data, search the hashtag #DataSavesLives.
Okay, so that's a nice little video that was produced a few years ago now. And if you are interested in more around that, I really do suggest you go over to the Data Saves Lives or the Understanding Patient Data websites, because they do a lot of really, really good work around this.
This film has been produced.
So leading then on to how we do this at Swansea. So Swansea is home to the Secure Anonymised Information Linkage Databank, or SAIL Databank for short. And SAIL has been doing this since 2007. So we've been doing it for about 14 years now. And we had our 10-year anniversary a few years ago. And SAIL is currently an internationally recognized best practice system. So we are world leading at this at Swansea. And there are a lot of now what are called trusted research environments, of which SAIL is one, that have really looked to SAIL as a champion of how to do this. And that's not to say we rest on our laurels here at Swansea. We're always developing, we're always innovating about how to do this better and in better ways. And it's a very busy slide here, and you'll get a copy of them afterwards, or they'll be on the video to look back on. But essentially, we hold a large corpus of data from across Wales and across the UK. We're talking about billions of records of data here for millions of people going back 20 years or more. And as you would imagine, requires a lot of different expertise to both manage that, to maintain it, to update it and develop it further, as well as then obviously using the infrastructure to enable the research with what is available. So just about how we do this in Swansea, I'm just going to play a really short video now, it only lasts about a minute, just to show you how we take people's data and how we ensure that we maintain privacy protection here in terms of the use of those data.
The Secure Anonymised Information Linkage Databank is a world-class anonymized data linkage system that securely brings together the widest possible array of routinely collected data for research, development, and evaluation. Our data providers will have a mixture of demographic or person identifiable data and clinical or administrative data in their files. The demographic or person identifiable data must be de-identified before entering the SAIL databank. It is the data provider's responsibility to split their data into two parts. File 1, the demographic or person identifiable data, will be sent to our trusted third party, the NHS Wales Informatics Service, or NWIS, to be de-identified, and File 2, the clinical or administrative data, to the SAIL databank. Both files require a unique record identifier field so that once file 1 has been de-identified, it can be sent to the SAIL databank by NWIS and paired back up with file 2, which then recreates a complete but de-identified data file ready for analysis by trained researchers.
There we go. So that's a quick look, and there's lots of information on SAIL online on the SAIL Databank website. So once again, if you're interested about SAIL, then I suggest you go over and have a look at the website. But essentially, a visual of what that video was talking about there is here on the slide, just as a backup in case the video didn't work. But essentially, it takes any origin data from any data source. It doesn't really matter where the data comes from. The supplier would have to split the data into two files. The data then goes to our colleagues who used to be called NWIS. They're now called Digital Health and Care Wales as of a couple of weeks ago. And they anonymize that for us. And the key thing here is at the bottom that before it comes to SAIL, all the identifiers are removed. So we never get to see people's names or people's addresses. That is all removed before it comes to SAIL. And we just get a list of random numbers, which don't mean anything to anybody. That's loaded into SAIL, but using those anonymized encrypted identifiers, we can then merge that together with all the other data that we hold And then that allows us to really do the power of what is SAIL to do our anonymized research. And really the power of that is what we call this geographically contiguous linkage. So with a very simple example, if one person moves house 3 times, if we didn't know who they were, every time they moved house, they'd become a new person in the data. Or every time they moved GP practice, general practice that is, they'd become a new person. Whereas because our linkage is all done in the same way, using the same base methodology, the same person can move, they can change services, they can be in different data sources, and we always know who that one person is through all the different data sources. And when I say we know who they are, we only know who they are anonymously. We don't know who they are, with every real details. But this is very, very powerful then for doing research. So using a very simple example of what we call patient journey analyses, we could see for a given person or a given set of people that they may have some records in accident and emergency data, they may have some hospital admissions, some outpatient visits, and sometimes where they go and see their general practitioner. Using SAIL then, we could propose an intervention, or we could review and evaluate a current intervention, and we could say, right, we now want to evaluate something. So using that data, we can then follow up in time after this and say, well, what happened after we changed something, or what happened after something has changed anyway? And also as new data become available, we can both go back in time and we can go forward in time once that becomes available to check things. And this really is the strength of linked, anonymized longitudinal data. And this is what allows us to do everything that we do in SAIL. And there's a wide domain of different data available. And here's just a snapshot of some of those data that we have used and we are now using as part of COVID. A unique thing to Wales as well, which we're able to do, as well as doing person-based linkage, we're able to do residential-based linkage. So this becomes very powerful, especially during COVID, which I'll come to in a minute, which allows us not only to look at a person's data, but allows us to look at a person's data in relation to where they live anonymously, but also who they live with anonymously. So we can anonymously look at where does somebody live and who do they live with, so that we can look at relationships between people. So whether this is with people they live with, live in the same area with, and some others that I'll come to show you. But once again, SAIL has been doing this pretty much since its start back in 2009. And once again, we're world leading in this when it comes to this kind of activity. And just to give you a high level example of what that allows you to do is what's called GIS, or Geographic Information Systems, is to do geographic data modeling. And here's some just very high level examples of what that allows you to do with some pretty data visualization, which is very important when you're trying to display your research to others so they can understand. But here's just a couple of examples where the pink data viz here shows the modeling of different transport routes. So that's really important when you're trying to understand what services people may have access to. Not everybody drives, not everybody is in walking distance. So it's a good example of how we use data there to model people's services. The bottom example was from a tyre fire that occurred in Swansea about 15 years ago. And as you would imagine, there was serious health implications from that tyre fire. So looking at where the center of the fire occurred, and then through pollution and other impacts, Public Health Wales colleagues were able to model this 10 years after the event to look at, for all the people that lived in that area at the time, did they go on to have asthma, COPD, and other respiratory type events. And then last one, which is something that's really interesting, is looking at where people live in relation to their services. So in this example here, you've got somebody who lives at the green dot, and they may have a choice of different general practices in their area. If you did this just in a very narrow way, you just look at what's called a straight line distance, but most people don't own helicopters, they can't fly, so you can't actually travel in a straight line distance. What you have to look there is at how you can walk, how you can drive, how you can get public transport. So using GIS and data that's linked to that to really model and really drill down into exactly how people are accessing their services, or what's even possible. So really important, yeah. Just want to draw special attention here to governance, because without without governance and without the ability to really show that what we were doing is safe and secure, we wouldn't have been able to do this. And we really feel like this is a very strong component of SAIL, and we put a very strong emphasis on this, both for the service at large, but also for projects and how they are planned out and how they are designed. So just to really, draw attention to the emphasis of this and the really the strength that this brings to the different processes. And through SAIL, we do this through different methods. One of those is we have a consumer panel at Swansea, which is made up of people from the public who bring their expertise and their time to inform different projects about how they might be designed, some of their results, and how they can be interpreted as well as taken forward. So just to say, the consumer panel is always looking for members. So if you're interested in that, please get in touch with them. They're always interested in new people joining the group. And another thing which I mentioned earlier is that we do a lot of training here from Swansea. We run a lot of different workshops. There is a shortage of data scientists in the UK, so it is something we do spend a lot of time on when it comes to sort of developing the next generation of data scientists. So I'm just going to now spend the next sort of the last half of the webinar just talking a little bit about what we've done in COVID. Okay, so as most of you will obviously be aware, the COVID-19 pandemic emerged across the world and in the UK especially around February or March of 2020. And from that point, very early on, we offered our services from Swansea as part of the Population Data Science Department to aid and support the ongoing evaluation with Welsh Government, with UK Government, and with different public health agencies. There's a lot of info about what we have done online already, and there's a link at the bottom of the slide. So if you are interested in more specifics, then please go to the website and have a look at some of the blogs and some of the activities. And just to build upon that, really, just to say that, the COVID pandemic changed everything for everybody. It basically altered all research, whether you were interested in COVID-19 or not. All research has been affected by COVID-19, both directly and indirectly, and more importantly, people's lives and services have been altered. So it's a very important thing that is still being studied now, but I would imagine will be studied for the next few years at least, in terms of the ongoing impacts both to people's lives and people's services. So what we did very early on was we came together and we organised what we coined as the One Wales collaboration, which brought colleagues together from a range of different academic, policy, government and NHS services to really see how we could work together to build upon our strong links across Wales of working together to date, but how we could really be as efficient and really look at the priorities that were brought to us at different times through the pandemic. And as you would imagine, early on in the COVID pandemic, those priorities were changing on a weekly, if not daily, if not hourly basis. And more recently, with regards to things like the vaccine rollout program and other things, we've also been asked to respond as things change, as you may have seen in the media and so on and so forth. So we organised the One Wales collaboration, and that's how we've taken things forward, as a very much a partnership and a collaboration effort, which would not have been possible if people had not worked together. So it really shows the power of working together and collaborating across the UK. And more recently, we've also started branching this out now to look at different subgroup areas. So through the British Heart Foundation, we are looking at cardiovascular specific outcomes. We're also looking at cancer specific outcomes and some others. So once again, learning from what we've done, being as efficient as possible and branching out and working in different areas with different groups to really push this forward. Okay. So I've mentioned some of this before, but I'm just going to leave the slide up for a second just so you can see the group that was originally involved. But just to repeat rather, is a phenomenal amount of work and progress has been made since last year and really has drawn upon our collaborative links. Here's a short slide of some of the team. If I was going to put pictures of everybody that's been involved, we basically use the rest of the webinar of me just showing pictures of people. So it's just to really echo that this is a really big collaborative effort, and here's just some of the people that have been involved in that to date. Okay. So just to cover a couple of things just before I show you some specific examples. So what COVID-19 has really done to data science and to trusted research environments across the UK in general, not just the ones in Wales, is really has pushed the boundaries in terms of what we had previously, what had to be re-engineered and engineered from scratch, and in some cases completely redesigned. So prior to COVID, as I showed you on a slide earlier, SAIL has a large variety of different data sources that were all available on different cadences. Just a different word for cadences is different refresh rates. So how often do we get those data? What COVID-19 has done is push that to its limits. So as you would imagine, knowing if somebody had been in hospital on a quarterly basis, so once every 3 months, probably before COVID was fine because you didn't really need to know anymore. That just didn't work for COVID. So what we've had to do is we've had to re-engineer all of our data flows with our different data providers to push them to the limits. So for hospital admissions data, for example, we now get that. We've moved it to a monthly data. That wasn't enough. So now we've pushed it to a weekly data. So where we've come from quarterly to weekly is significant now. And what that allows us to do is to look at admissions that happen in hospital with only really a fortnight of delay. So really allows, pushing the edge when it comes to looking at intelligence. And for other flows, for example, the vaccine rollout, for mortality, for emergency department, we're all the way down to a daily flow. So as of last night, we'll come into work the next morning and we'll see data from yesterday, which really allows us to push the boundaries when it comes to intelligence generation. The second one on the slide is about new data. So obviously a lot of new data has been generated from COVID in general, just because they're new data sources, but a lot of different data sources that we didn't have access to before due to COVID and their importance. We've made a lot of progress on getting access to new things. And it's just to say once again that the work is not done. There's always more things, there's always more data, there's always more activities we can be doing. So I'm sure there'll be more developments moving into the future as well. And what that's really led to is, once again, Wales and Swansea being on the map when it comes to some of these things. So what we provided to SAGE, which is the UK level group that is responsible for organising COVID response, is very early on. SAIL and Wales was recognised as having probably one of the most mature infrastructures, but also really being at the forefront of enabling this type of activity. So here's one of the reports that we used to produce weekly and now fortnightly for SAGE through Health Data Research UK, and really showed some of those significant active research steps and developments that we put in place very early on. And this is just a snapshot of one of those slides very early on that showed at one point SAIL had pretty much 2/3 of all of the active research that was going on around the UK. I think now all of the other TREs are at a very good place, and we work very collaboratively across the UK now, doing UK-wide research. A byproduct of COVID is a lot more data sources have been available, but a lot more metadata or documentation is now available. So this is really important. Going back to my point about having not enough data scientists or not enough expertise, is there are people with certain expertise, but in certain areas. So having really good documentation and understanding what is available is really important. So a lot of work has been done on this, which we've been involved in. And just to say, this is now all available on a central website, so anybody can access it. You don't need an account. You just go to this website and you can search here for data across the UK. So if you're interested in the data from Wales, search for the word SAIL, but you can generally search and find the different data sources, the different projects that are ongoing, a lot of different information. And it's all available to the public. That's really important. So what we did from Wales was we built upon some existing work that we were doing prior to COVID, which was around multimorbidity. And effectively, multimorbidity is just a person who has 2 or more conditions at the same time. And we took that existing work and we pivoted it effectively to respond to COVID very quickly. So we used that model and we built upon it. And just some very high level information as to how we did that. But essentially what we do for a lot of our research is we look at what's happening now. So we look at what's happening from 2020 onwards. And we use prior data, so whether that's 2019 or looking at 2016 to 2019, to really say, well, is what's happening now, is that novel? Is that something that's interesting to look at? Or is that just relevant because things have been changing for the last year or the last 4 years anyway? So what has been the actual impact of COVID? Can we try and evaluate that as closely as possible? So we update this on a monthly basis. This slide's a little bit out of date. So at the moment, that data is up to date until the end of February. And by the end of this week, it'll be up to date until the end of March. So once again, really pushing that boundary on what's available and what we can use. And because we work in academia, we like to publish. So we've published a lot of papers, and this is just one of them that shows how we've done that work, how we've organized it. And once again, so others can then come in, see what we've done, give us input into that, help us see where we could improve it, and others can build upon our work. And on the left just shows some of the areas of different work that we have ongoing and or that we plan to do more work on soon. So if I just give you some examples about why data science is really important and what we've been able to do with it. So if I just show you this slide and the next one, just to show you why it's important to understand your population. So where we are looking at multimorbidity as an example and looking at hospital admissions data, using a set of codes that are known nationally or internationally. If we just show here what's happening in 20 to 29-year-olds, you can see from the image the areas that are affecting younger people more. Okay. If I show you then the same image, but now we're looking at 70 to 79-year-olds, you can see that what's affecting older people is very different to what's affecting younger people, okay? So understanding the groups that you're looking at and what may be affecting them is really important. And this is what a lot of data science is about. It's understanding the data you have, understanding not only what it means from a technical point of view, but working with clinicians, with people in the NHS, with what we call domain experts, to really understand what we're looking at. Does that make sense? And is that something that we can then give back to the people who make decisions on services to make changes? So very early on, as I mentioned, we started expanding the amount of different data sources we had and how we could use them. And this led to a lot more challenges than you would imagine in terms of having, for example, this is an example of A&E data. So on the left-hand side, it shows you a monthly flow of A&E data versus a daily flow in red. And as you can see there, the trends are largely the same, but there's a gap. And we needed to understand what the gap was. And after we looked at the data and we did some cleaning and we reorganized it, we then moved to the graph on the left, which, as you can see now, once we kind of organize the data and understand why the differences were occurring, the colors largely overlap. And we're now able to use two different data sources on different refresh rates to really expand the possibilities of what we're able to do with some of these data. Staying with A&E data, so this is just a graph that shows you the impact of COVID on emergency departments. So you can see at the start of it that emergency department is fairly well used in Wales, as I imagine it would be across the rest of the UK. The national lockdown came in March, and as you can see, the graph completely plummets because people just stopped going to A&E, both due to the lockdown itself, but just due, as we know now from speaking to clinicians, people were worried about going to A&E in general. Like even if they were ill, they weren't going to A&E because they didn't want to take the risk of acquiring COVID. And you can see here that A&E largely starts to recover in terms of the rates of people that are attending A&E. And then when we had the fire break in October, there was a small dip, and you can't see it on the graph, but once again, later in the year, then it recovered in terms of the number of people. So it was really important to see this because we were looking at this on a daily basis to be able to really understand people interacting and accessing their services. And what did that look like in terms of comparing emergency department to hospitals? So if you look at the 5-year average, which is the blue line of people in ED and then coming to hospital, you can see that just in 2020, it just completely plummeted and didn't recover for a long time, and to a certain extent hasn't still recovered in terms of hospital admissions. And the same thing in outpatients data, essentially. So looking at the 4-year average compared to the 2020 numbers, you see a similar picture in terms of attendances at outpatients. So why this is important to understand is that where you are looking at COVID or where you're looking at non-COVID research, you will notice a massive drop in the number of people and the amount of records. So we need to understand not only that it happened, but how it recovered in different areas, different specialties, and obviously just the impact of COVID itself for those people. Care homes has been a big topic of discussion. I'm sure you probably would have seen in the media for the last year. So we've done a lot of research into understanding the impact of COVID, both direct and indirect, on people that are resident in care homes. There is a lot of data out there. There's a lot of findings out there. I'm just going to show you one example with regards to survival rates in care homes between January and April last year, which we published. But essentially just to say that care homes is a very complicated area of research due to the different factors that you will find in care homes with regards to, people living together, the infection rates, but not only that, they are a community in a care home. So you'll tend to find that they deploy services and they deploy interventions in set ways. So a very interesting area of research and very impactful then in terms of some of the information we've provided back to both public health and Welsh Government. Ethnicity research has also been very at the forefront of COVID-19. So with regards to Wales does not have a very ethnically diverse population, especially if you can compare Wales, for example, to London or certain areas of the north of England. But that's not to say we shouldn't investigate it in Wales. It's just to say that we would have different things that we would look at, or different limitations and or expectations in terms of how we could use that data. So ethnicity is a bit of information that is collected in a lot of different data sources, but I think what COVID has shown is that it's probably not collected enough and to the quality that it should be due to its role in a variety of different public health and data science questions of relevance. So what we did very early on was we looked at some of this, and then what we've done in Wales as part of our group is we've used the power of SAIL to basically link over 20 different data sources together, as well as the ONS census, to really try and get as much information on ethnicity as possible. So using just health data, you'd probably be missing about 26% of the population who have no ethnicity information. If you use the census from 2011, you'd be missing about 35%, which is understandable because it's 10 years out of date now. But by merging all of these together, we're able to get that missingness down to, on this slide it says 8%, I think more recently we managed to get that down to 6%. So we now have coverage for over 90% of the population in terms of being able to enable that type of research. So using the power of what we call big data to its strengths. And here's some other examples of what we've done. So using positive COVID testing data to look at, prior to somebody having a positive COVID test, what type of services do they interact with? After they had their test, what type of services and or outcomes did they have? So once again, using the power of longitudinal linked data to look at a lot of different data sources and draw as much information out of them as possible. And a similar example for something called the shielding list, or the clinically vulnerable list. So looking at, from the point somebody was told to shield, what happened to them before and what happened to them afterwards, so that we can try and inform the people designing the shielding lists, or informing people about how and why they need to shield. What type of impact did it have? Evaluating it, did it have an effect? Was it something that had a benefit? The Zoe symptom tracker data you may have heard of. Some of you may have even filled it in terms of the application. So using this, what's called patient reported outcome data, or PROMs, which is very, very useful from people in terms of them submitting their own information. So using that to really draw information and possible things that are going on, which isn't available in routine data. So people that aren't going in for services, but might be filling data in on an app. So using that kind of data to its strengths. And this is an example of using that data pretty early on to look at hotspots. So what was going on with COVID, and I believe this is still going on to this day. So if you're interested in this, if you haven't used the app already, or if you haven't heard of it, the Zoe team do put out a lot of information through social media and through their websites about what they think is going on in the country based on patient reported outcomes, as well as other data. The benefit from Wales is we have both data sources, and we've been able to link them, so we can look at the PROMs and we can look at the routine data. And I'm not going to dwell on the next few slides, I'm just going to show them quickly, and I'm happy to take questions on them later, but essentially just to show the complexity of some of this, the data, but what it allows. So we have testing data now, but how do we use testing data? How do we draw conclusions from people that have had positive or negative tests, and how do we use that data? And one of those examples at the moment that we're working on is looking at healthcare workers. So looking at, for different healthcare workers who work in the NHS, patient-facing versus non-patient facing, and really looking at how, this was last year, but how the rates of testing changed over time with different testing types. So I'm not going to go into the technicalities here, but there are different ways of testing people, and showing really how the impact of that testing really changed over time for the different groups, as you would imagine, but also the availability of those different types of testing that changed over time. Another really powerful thing, which you may have seen in the news, the Welsh Government, the First Minister used it at one of his press conferences last year, was showing the community prevalence of COVID across Wales. And you might have seen this. This was one of the things I think that was used to inform the second lockdown, was showing that as COVID evolved, there's a really nice video of this online that shows just as COVID outbreaks in certain areas, how it then expands and escalates and transfers around the country. So using the power of this, as close to real-time data as possible to model those things. And more recently, we've done work around schools. So using linked data to look at both the teachers and other people in the workforce that work in schools, and obviously the staff and the students that work, the staff that work in the schools and the students that attend the schools, to really look at the impact of COVID, because obviously last year there was decisions about closing schools. So how can we use that data using these different complex linkage methods to come down to a cleaned cohort and then make decisions about what's happening? So if an infection occurs in school with staff or with students, how does that then play out in terms of the infection rates, and how does that play out in terms of the different interventions that we could design in the future? And that's another one on those. So just to quickly round off just some of the other things, I think I've got a few slides left. So we hold all this data, we take it very seriously in terms of security. So we hold a range of different accreditations when it comes to those kind of things. And there's a nice little graph here that shows the number of times that we're attacked in terms of our infrastructure by hackers and other people who want to get access to those data. So it's really important that we have access to these data. The SAIL team take it very seriously, and they really ensure that that data is kept safely. We are interested in what's called emerging data types. So there's things, there's a few slides I'm just going to show you now. So natural language processing essentially is taking free text documents. So you might think of a letter that you sent when you get discharged from hospital, or a letter you might get sent from your GP. So how do we take those type of non-relational data, not a database, not a spreadsheet? How do we take those data, push them through an engine, and turn them into a structured data set so that we can use them for research? So we're doing a lot of work around this. Actigraphy. Lots of people these days have I'm not going to name specific brands, but a different type of watch or a different type of app. So how can we use these types of data to inform data science as well? Because these are all, really useful, novel, different data sources that we can draw together. and genomics as well. So how can we use different things? You know, you'll see a lot of this in COVID now, the word variant. So how can we take this different type of information? How does it play a role in understanding what's going on or planning for the future? So data science is what I'm trying to say is, as we said earlier, data science is a very big, large area with lots of different disciplines, lots of different expertise. And it's how do we bring all those different expertise and disciplines together to really answer those type of questions? And that's it for me. So that was a very quick whistle stop tour. I'm more than happy for people to contact me afterwards if they've got any questions. But just to say, that's just a very small sample of what we have been doing and what we are doing. And as I said, more than happy to take questions now or later on if people want to contact me.
Thank you very much, Ashley. And that was really interesting. It's really interesting to see the population data science research and overview, and also the range, the different aspect that's also relevant just to COVID, that, you know, the type of research that's been undertaken. So we've got Ashley's contact email address on the screen just now, or if you're watching this on the recording, then please contact us on study@swansea.ac.uk if you've got any further questions after today. Thank you very much.